So Jeff Hanna, who's research associate in the school, who joined us during the pandemic. You've been remote worker, yes, throughout your employment at Strathclyde. So thank you for offering to do a presentation. I know this is part of your doctoral work, isn't it? Your project. So presenting on facilitating family support for when a parent of dependent children is at end of life. So are you okay to take about 15, 20 minutes, Jeff?
Yeah, that's good for me.
Great. So over to you. And just to say, we are recording this session. So if you don't want to appear in the recording, you can put your camera off, everyone. And if you want to type comments in the chat, I can read them out. Thank you.
Okay. Thank you very much, Daniela, and good afternoon, everyone. Thank you for joining us for our seminar series. I'm going to present over the next 20 minutes or so on my doctoral research, which was facilitating family support when a parent of dependent children is at end of life from cancer, and this research was completed at Ulster University. Just in terms of the presentation this afternoon, I'll take you through very briefly on the background literature to this research area, brief overview of the methods deployed, a snapshot of the key findings from 3 qualitative studies, and the implications of those for practice and policy. So in the UK, it was estimated that 23,600 parents died in 2015, leaving an estimated 41,000 dependent children. It is estimated that 5% of children living in the UK will experience the death of a parent before the age of 16. So one of the greatest challenges faced by parents is how best to prepare and support their children throughout the end-of-life cancer experience. Often, parents feel it is protecting their children by not preparing them for the death of a parent, but children who are less prepared for the death are more susceptible to psychological poor adjustment in later life. And this is compared to those children who are prepared for the death of a parent and involved throughout the end-of-life experience. So the aim of this study was to explore how parents can be best supported when a parent of dependent children is at end of life. And the first phase within this research was to conduct a systematic review of the literature, and this review has been published in Palliative Medicine. Very briefly, the aim of the review was to synthesize the evidence on the experiences of parents and children when a parent is at end of life, to identify their challenges, support needs, and factors that facilitated good practice. The inclusion criteria was adults with a non-curative illness and have dependent children less than 18 years old. Qualitative and quantitative studies were included using any research design or analysis. 4 electronic databases were searched with no restrictions on the year of publication, location of the study, and the language it was published in. Over 7,800 articles were identified, 112 were screened at the full text stage, and 27 qualitative studies were included in the final review. So a brief outline of some of the key challenges faced by parents at end of life. Parents desire to protect their children from pain and upset. They feel that children will not understand the severity of the situation. Some parents have opposing parental beliefs on how best to prepare and support their children. Some parents are uncertain of how best to prepare their children for the death. Some parents have a lack of clear understanding surrounding the poor prognosis themselves and thus do not feel confident to share the news with the children. Some parents feel ill-equipped surrounding the appropriate language to use to share the news with the children. And many parents are concerned surrounding difficult questions the children may ask, no more than, how are you, or are you going to die? Parents have also reported a lack of supportive guidance and advice from health and social care professionals on how best to share this news with the children and involve them throughout the end-of-life experience. And that's something I will pick up again shortly. Key needs of children throughout the end-of-life experience. Children desire to be informed and involved throughout the period. They desire for time together as a family and to create memories for the future. They want to be part of the saying goodbye experience, and they desire for opportunities for routine to be maintained, such as attending their usual clubs and societies and going to school. Now, I did very briefly just pick up on my systematic review that one of the key requirements for parents is supportive input and guidance from health and social care professionals. The structure of clinical services means health and social care professionals have regular contact with parents at end of life, affording them with unique opportunities to provide support to parents as they prepare their children for the death of mum or dad. The findings from a systematic review by Penny Franklin and colleagues at the University of Surrey identified a number of obstacles for health and social care professionals in the provision of this aspect of care. Some of these included a lack of confidence to engage in conversations, feeling emotional overwhelmed and having them, a lack of professional experience as a health and social care professional to provide meaningful support, and a lack of time. But within the research that's existing to date, there is a number of research gaps. First of all, there is a lack of clear understanding from the literature surrounding how parents manage daily family life with their children when a parent is at end of life from cancer. So for example, what does memory making look like? How do parents prepare their children for the death? What is the timing of this? What does that end of life experience look like? The literature also lacks details surrounding what language is helpful for parents as they prepare to share information with their children surrounding mum or dad's cancer throughout the end of life period. Current literature has also predominantly explored the needs of mothers with advanced breast cancer, attending support groups and services, and have direct supportive involvement with family support workers or social care professionals. So it's not clear how families navigate this experience in the absence of this support. And of course, the literature is largely underrepresentative of fathers. And also, what is the role of health and social care professionals? We understand that they find this aspect of care to be particularly challenging, but it's not clear what it is they're providing in routine practice, which this research aimed to set out. So very briefly, this was an interpretive qualitative inquiry where 4 sample groups were involved: parents at end of life, bereaved parents, and health and social care professionals, which was guided from what was existing within the literature of the groups to interview and involved within this research. Data from the interviews with bereaved parents repeatedly referred to the funeral director as an instrumental source of support for the bereaved parent after the ill parent had died. And this was particularly evident in those interviews where the period between poor prognosis and the death happening was relatively short, and also where there was lack of supportive involvement and input from health and social care professionals throughout the end of life trajectory, and therefore funeral directors were also included within this research. The 4 groups were recruited using convenience, purposive, and volunteer sampling techniques. Qualitative, semi-structured interviews were used. Topic guides guided each of the interviews, which were iteratively modified between and within each of the sample groups throughout the data collection process, and data was analysed using Braun and Clark's thematic analysis. Overall, 79 participants were involved in this research, comprising of 3 parents at end of life, which were 3 fathers, 21 bereaved parents, 32 health and social care professionals across acute and community settings between specialist and generalist roles, and 23 funeral directors. I'm going to first of all present the findings from those of the bereaved parents. This has been written up and has been accepted for publication in Palliative Medicine. And it's also important to highlight that the findings within the bereaved parents also mapped and mirrored those 3 end-of-life parents who were also included within this study. So what are the key findings? Well, many parents are living in parallel worlds throughout most of the end-of-life experience, characterized by mainly choosing to live in the moment. Parents were savoring everyday life with only occasionally thinking about the impending death. And often, everyday life was encapsulated in 3 key areas. So the first of these, life goes on and adapting the poor prognosis in the family. So it was important for parents to maintain previous parenting roles, routine, and responsibilities in the family, despite the physical constraints imposed by the ill parent's cancer. So this included the ill parent continuing with aspects of parenting they practically and emotionally could manage, such as helping with homeworks, sorting out play dates, making lunches, whatever that looked like. At times, though, it was necessary for parents to adjust routines throughout the end-of-life experience, especially if the ill parent required hospitalization. And maintaining routine became more effective and less achievable for the family as the ill parent's health was declining at end of life. Making the most of ordinariness and capturing life as it happens. So as parents anticipated those future disruptions and losses, there was an evident keenness to do more activities with the children. So parents were intentionally focusing on cherishing the everyday happenings within the family, such as going for a walk or getting an ice cream. And many more photographs and short video clips were taken, motivated by an effort to capture the moment and have lasting memories for the children. The third area then, which was striving to live. So low parents reported a keenness to make the most of ordinariness throughout the life of the end of life period, And while they had knowledge that mum or dad's cancer was potentially curative, was not curative, some remained hopeful that the ill parent would either survive their cancer or would have many more years to live. And striving to live was encapsulated in two key areas: the hope in treatment in prolonging life, and the hope that the parent would be healed from a religious or spiritual faith. Then, for variable periods of time, it appeared parents coped by adjusting and getting through the ups and downs of treatment, with home life going on as usual. Then the ill parent declined very quickly, moving hastily to the dying period, typified in days or short weeks. And often this was triggered by an apparent complication for treatment or more rapid disease progression at the end. And for many, this led to a hospital admission and the parent's death. At this pivotal point in time, parents did get a sense that they were running out of time as a family, describing the feeling as falling off the cliff. So despite parents' devoted focus on the needs of children throughout the end-of-life trajectory, when death became imminent then towards the end, children appeared to be on the sidelines. So there was an obvious lack of parenting capacity from either parent, as well parents' attention was focused on the dying partner, and input from close social family networks, mainly that of male family members, was frequently necessary to help with the practical aspects of parenting at this juncture. So the second qualitative study was with health and social care professionals. This paper has also been written up and has been published in Psycho-Oncology. So health and social care professionals highlighted the importance of providing supportive care to parents at end of life regarding the children. However, the provision of this care was considered by most health and social care professionals as outside my remit. Professionals working in the acute setting reported clinical interactions as too short and focused on the ill parent's treatment needs, and perceived any parental needs at end of life in relation to the children were picked up by community teams. However, the opposite of this finding was also reported. Parents also felt it was like navigating an emotional obstacle, or health and social care professionals, felt it was like navigating an emotional obstacle course, transferring the pain of what if this was me and my family. Many felt that they might get upset and that might appear as unprofessional. Some health and social care professionals felt they had a lack of rapport and confidence with some parents they had just met to engage in sensitive conversations regarding the children. And some clinical areas, or even the home, was described to have a lack of privacy to engage in sensitive conversations regarding the children. So while many health and social care professionals felt ill-equipped to be able to provide supportive care to parents in relation to their children, they wanted to be provided with training and support to be able to deliver these aspects of care. They also reported that many parents were also concerned in relation as to whether or not they should tell the children that mum or dad was going to die. And the key obstacles was protecting the children from being upset, parent living well and not feeling the need to tell them yet, or parents focusing on hope that the parent could be cured, or different parental beliefs on how best to do it. Health and social care professionals also stated that many parents were unsure of how best to tell the children that mum or dad was going to die. And while some did report experiences of supporting parents to have this conversation, most felt ill-equipped and able to do so. Health and social care professionals described that there was ongoing and changing needs for parents throughout the end-of-life period. Often, the well parent was described as juggling different parental roles throughout the end-of-life period, such as looking after the ill parent, or in some cases being the sole breadwinner within the family. Some ill parents also were appearing to struggling to do everyday parenting activities as a result of their declining health. So this may have included taking the children to school, cooking meals for the family, and so on. Some of the community care nurses and allied health professionals did outline examples of helping ill parents to practically carry out the parenting role at the end of life, such as sourcing volunteers to help with grocery shopping or obtaining physical aids so the parent could attend their child's sports day. Then, as death became closer towards the end, health and social care professionals perceived many parents were concerned about how best to prepare their children for the actual death. So how do they tell them that mum or dad is coming home from hospital to die, is not coming home from hospital, or was going to be moving to a hospice? Parents were also reported as concerned as to whether the children should be present, and parents were also reported to be concerned on how best to prepare the children for this, to which health and social care professionals perceived that many parents also were unaware of the physiological aspects of death and dying themselves, and thus were less able to share this information with their children. The third qualitative study was with funeral directors, and this has been published in Death Studies. So before face-to-face contact between the funeral director and the family, it was reported that some bereaved parents had struggled with finding the appropriate language to tell young children, typically up to 12 years old, that mum or dad had died. Funeral directors often described the immediate bereavement period as chaotic for the newly bereaved family, as it was usually their first experience of an immediate family member's death. Bereaved parents were often described by funeral directors as uncertain as to whether the children should be present when funeral arrangements were being made, and they were also unsure about the child's involvement throughout the home, during the wake, or if young children should attend the church, graveyard, or crematorium on the day of the funeral. And funeral directors also perceived many bereaved parents were unsure if bringing the body home would expose the children to heightened levels of distress. Death was also described as being difficult for any family. However, funeral directors described observing a more emotionally charged and raw situation when a parent of dependent children has died compared to that of an older person. And funeral directors also reported greater levels of distress when working with families when a parent of dependent children has died. Now, the role of the funeral director varied in supporting families throughout the immediate bereavement period. While some felt their role was limited to organising the logistics surrounding the funeral, others reported more supportive involvement and a pastoral role throughout the immediate bereavement period. For example, funeral directors were encouraging some families to involve the children in the planning of the funeral, such as choosing some of the music, choosing the flowers, and also involving them on the day of the funeral, such as giving a reading within the church or throwing a flower into the grave. And funeral directors also highlighted that societal shifts are influencing the immediate bereavement period when a parent of dependent children has died. So what does all of these studies mean for practice, and how can this shape the care that health and social care professionals are providing to families when a parent of dependent children is end of life from cancer? Well, if we take a look back to the diagram theory that we have presented from the bereaved parents, I'd like to talk about some of the key implications of how health and social care professionals can best support. So there is a need for clear and honest information surrounding the reality of a poor prognosis. Health and social care professionals should provide clear and honest information regarding the poor prognosis and ensure that parents understand the severity of their condition and have realistic timescales. Parents should also have an awareness that death is going to be the inevitable outcome from the poor prognosis. At the time of receiving poor prognosis, there is also the importance of early preparation. So health and social care professionals should acknowledge with parents how difficult it will be for them to share the news with their children that mum or dad is going to die from cancer. So what are some key tips for healthcare professionals here? They should reassure parents that by telling children the reality of the situation, they are protecting their children, and encouraging parents to share the difficult news with the children as soon as possible would also be helpful, as it's likely that children will understand that something is wrong, and knowing the reality of the situation can protect them at a distressing time. Also, parents should be encouraged to be honest with their children that the parent will eventually die from their cancer, avoiding false hope. Parents then should be encouraged to use plain language with the children when sharing the news with them that mum or dad is going to die, using terms such as cancer and dying. Parents should also be advised to forward plan for the future at the time of receiving the poor prognosis, or in the early weeks or days when the ill parent is still well. So they should reassure parents that now would be the best time to have difficult conversations or make plans surrounding the future, as the ill parent's health could deteriorate at any time and they may not have the opportunity to do so. And forward planning can provide comfort to the family after the ill parent has died, in that they are fulfilling their wishes, and it can also aid security for the future. And forward planning may include things such as outlining funeral wishes, managing finances, legalizing guardianship for the children if that's appropriate, and having difficult conversations surrounding future aspirations for the well parent and the child. Then, as the ill parent's health deteriorates then towards the end of life, if and where possible, health and social care professionals should reassure parents to provide children with the choice to be present when the ill parent is actively dying. They should also inform parents of the physiological changes associated with death and dying, and providing them with the language as they share this information with their children. Parents should also be encouraged to involve the children then throughout the immediate bereavement period. And part of end-of-life care should include preparation from health and social care professionals surrounding the death and those immediate following days. So it would be in the best interest for parents and children that this is being talked about, or it has at least been thought about. So this may include what they're going to say to the children and how the children may be involved. Now, appreciating that all cancer deaths can be different, there can be a sense of how it may look. And what is known is that there will be a parent that will have died and how the next few days will pan out. For example, are the remains going to a funeral home? Are they possibly going to be waked at home? And what will the role of the children be at this time? There's also a need then for family-centred care at end of life. So health and social care professionals can have an important role to equip parents in reaching care, to support their children when a mum or dad is dying from cancer. The health and social care professionals involved in this study did highlight their requirement and desire for training in order to enhance their knowledge and confidence to provide these aspects of care. Policy guidelines should also be developed to incorporate this aspect of care into routine clinical practice. Also, to support funeral directors and health and social care professionals' provision of this aspect of care, opportunities should be made for them to offload the emotional impact of providing a service or supportive care to families when a parent of dependent children has died. So what are the next steps in this work? Well, there is a couple of additional publications which we are hoping to be sharing within the next couple of months and are currently under peer review. Alongside colleagues at King's College London, we have developed a 10 useful tips resource to help parents and carers with a life-limiting illness have conversations with their children. We are hoping that this will be launched later this year at the EAPC conference in the autumn, and we look forward to sharing with those at a later time. I'd just like to extend my gratitude and thanks to my supervisory team at Ulster University, Professor Ilish McCacken, Dr. Cher Semple, and Dr. Esther Beck. Also to the parents, health and social care professionals, and funeral directors who were involved in this study, as well as the charity partners who have had continuous involvement. I'd like to thank you for listening to my presentation seminar this afternoon, and I am aware that questions will probably be asked towards the end of the seminar after Robert's presentation. Thank you.